quickly take you through the aims and the objectives of this webinar series when they come up, to remind us all. So the webinar series is funded by the Economic and Social Research Council in the UK, and our aims are to bring together academics, policymakers and practitioners from different countries to share our experiences of measuring, comparing and using mortality data about people with learning disabilities, to try and advance research into mortality of people with learning disabilities sufficient to allow us to make influences at national and international levels, and support the development of practical initiatives and strategies to address common concerns identified by the data. And apologies if I'm slipping in the term learning disabilities instead of intellectual disabilities, because that's the term we commonly use in the UK, but by that I do mean people with intellectual disabilities. We use those terms interchangeably. So the next slide should just quickly recap the seminar series. So this is the third webinar. The first in October last year discussed what we currently know about mortality of people with intellectual disabilities, and both the slides of the first and the second webinars are up on our web page, so you can go back and have a look through those if you missed those webinars. And then the second webinar last April, which seems like only yesterday, focused on definitions and the data that we have available across different countries, which was a really helpful webinar, I think, and again, a summary of that is up on the web page. So with that, I'll just hand over to you, Helene, to take us through your presentation, and then we can have a discussion after that. Is that okay?
Perfect. All right. Well, thank you very much, everyone. I'm Hélène Escoons, and I'm at Queen's University in Kingston, Ontario, Canada. I guess there's one other quick scan question, and these is to help people practice with these, because we'll have a few throughout. We're being taken to this. It's whether you've attended one of these webinars before, both, or only one of the previous webinars. Get a sense of where people are starting at. Okay, so a number of people have already attended both webinars, and others have going only on it. So that's great. We're hoping, as Pauline mentioned, that we keep building this sort of community of practice and exchange opportunities. So do feel free to invite others to join. PowerPoint properly. So the current webinar is about the ethical and legal issues that we may have faced or need to anticipate as we proceed with the work. Unlike the previous webinar where we were trying to reach consensus on definitions and data elements and so on, the purpose of this particular webinar is more to increase awareness of the issues to consider and to share experiences on how we've addressed them and help each other out as we move forward. What will be covered are some general sort of considerations or principles related to ethics and law that are particularly of concern for the work that many of us are undertaking or planning to undertake. And then to focus on the experience in Ontario and the work that we've done here. Throughout, though, there'll be polls and opportunities for people to chat online by typing in comments and questions. To learn about the processes and barriers in other places, so in other countries or even in Canada, in other provinces, because systems are a bit different everywhere. So in thinking about this, the way I think of summarizing this, the legal and ethical issues, is that they exist because of everything has to do with ownership and custody. We want to be able to access and use information that belongs to others and that is in the hands of others, or being managed by others. So a lot of the issues that we will face will really depend on what the role of the person whose data we're talking about, whose information we're talking about, what their role is in releasing the information or making it available to others. So you can think about it in terms of conducting a survey and asking individuals with intellectual disabilities themselves for information about them, in which case they are consenting to give you that information. That may be an approach that's used in some jurisdictions, but in many places, if we're talking about population-level data, that just isn't feasible. So rather than asking people to provide us directly with information, we are having to deal with what we call custodians of information. So they are the administrators of various programs who have information about persons with intellectual disabilities that will allow us to describe the population, so to get at the denominator that we've talked about in the previous webinar for our calculation of rates or proportions, and importantly about mortality in the population. So one of the things that's become apparent in recent years is a real shift from data custodianship, where agencies hold and keep data secure, to one of stewardship, where those same entities are trying to enable access to data. In this age of information and information technology, there's more and more efforts to make data available for the development of policy decisions, for advancing knowledge, and so that bodes well for us in trying to do this work in this current era. So I'd like to get us started on this by discussing a little bit who are the custodians, or who is the custodian of the data that would be required to derive mortality statistics for persons with intellectual disabilities in your jurisdiction. So as a quick quiz, it's not exhaustive, but just to give a sense of whether your organization is the custodian for all the data that would be needed, or some of it, or another organization is. And then if there are multiple custodians, if you could describe who they are and the data that they hold. That will give us a sense of who we're having to approach in our various places, access the data we're talking about. Well, type our answers.
Can I interrupt? This is Anna Cooper. I'm phoning because I've been unable to connect. Are people typing?
Yes. You can...
I can't see that, and I can't type in, but I can add stuff if you send round minutes or something.
Will do, and certainly feel free to speak up. We just can't manage having everybody speak at once, but anybody in the phone, do let us know. Try to answer those questions as well, and that way that'll benefit the whole group.
Anna, do you want me to send you a copy of the slides so that you could follow them? Is it okay? Oh, you're not on a computer, are you? Sorry.
Well, that's the question. I think if you could email me them, I could follow it. I don't know. I'm feeling useless. I haven't managed to get into it.
Oh, right. Okay. So let me see if I can just download them and email them to you then, and then you can at least have them.
That's really kind.
Yeah. Okay. Let me just do that.
Okay. So we're hearing, or we're able to read here that most people are acknowledging that another organization is custodian for all the data that would be needed. So health and social care system, the coroner, Matt is telling us about that. In the U.S., state developmental disabilities agencies, disability services, mortality register at the state level, or a mortality register at the national level. So, and then Chris talks about, Chris Hunt here, and maybe Chris you can expand on this, that the Health and Social Care Information Center holds the data, but they gain it through a range of places, which may have different rules and regulations. So that's certainly the case. And there are,
sorry, Chris. Chris, I think your microphone is picking up. I have to mute.
Hello.
Yeah, sorry, Chris.
okay, and Chris specified that the biggest block is data linkage. So we'll come to that part as well. We'll discuss that. In the Social Welfare Administration, federal and state statistics centers, I don't know where Daniel is based.
I'm based in Kent.
Okay. So big hospital trust with 1,700 people flagged.
Yeah.
And if majority of individuals die in hospital, then it's possible to...
We do keep that information on our systems, and we are able to identify when we go and look at those individuals' files that it does pop. We do get a pop-up saying this person has died. But I'm pretty sure from our information systems we'd be able to pull out a lot more data about that.
Okay, there are still people typing, and I certainly don't want to close that off before people have had a chance to give their input. Don't have access to health insurance or hospital data. Okay, Friedrich, where are you based?
In Germany.
Germany. Okay. Yeah, and those will be common data sources used in other places, I suspect. That is an issue.
Yeah, and we are not allowed to combine data from the health insurance with the social administration data.
Okay. And maybe when we describe what is done in Canada, there might be some insights, and then from other countries as well, about how this has been made available, been made possible. It's certainly not something that happens quickly. Okay. Wonderful. So we will have captured all of your comments here, and we'll come back to those particular realities that you face as we move forward. Gotta go back to PowerPoint. Multitasking. So the ethical and legal issues to be considered, and the reason why it's so difficult in many places to obtain this information, have to do with the particular sensitivities around the respect for individuals' privacy, and particularly around health matters. So this is not unique to the field of intellectual. Many jurisdictions will have specific privacy laws that apply to health information. That's certainly the case here in Canada. So the respect for privacy is important, and the confidentiality of personal health information. We add on to that the vulnerability of persons with intellectual disabilities, so that there are often concerns that the information about a vulnerable group might be used in ways that would further stigmatize them or cause them harm. So that's another consideration that we face in trying to access information from those who hold the data. The other ethical, particularly an ethical requirement, is that the benefits of accessing data and making data available to researchers or others is that it must outweigh the potential harm. So it's a question of managing risk, and once one has been able to demonstrate the value of doing the work, I think the fact that we have this particular group, international group, all identifying the importance of having routinely collected and standardized information on mortality for this population bodes well in terms of helping us all make that case in our respective jurisdictions that benefits can come from this. But the onus will be on us to demonstrate that to either the data custodians or to ethics boards, research ethics boards, to demonstrate that. So the more successes that we can share in terms of showing that analyzing the information, making it available has benefited the group of individuals with intellectual disabilities or the population, the better that will be. So I think it's very important to continue to stay connected and work together. Now, these various issues or concerns will may be differently perceived in different places, or because of the way systems are organized, or because of sensitivities in different places. So the next question that I have asks you to indicate what you see as the most challenging issue currently in terms of these legal and ethical considerations. What is the biggest barrier to undertaking the work? We've got other. Be interested to hear what people are identifying as other. Yeah, we run into issues of the technical issues, and that's certainly beyond the legal and ethical considerations, but certainly the ability to link information is relevant. Often that may come back to legal and ethical issues if it's a question of security. How does one link data securely while still protecting people's right to privacy and confidentiality of the information? Okay, so what is done with the information? So being able to show that there will not be harm created by passing information on to commercial insurance companies or like that. Quality completeness. Lengthy data cleaning organization before data can be used. Yes, absolutely. Yeah, Chris is a good point about opting in. That is often been a response that we've obtained when trying to access certain data, that when people provide data to custodians, they need to be aware that the information may be made available in a secure way without identifiers to others, and then knowingly then provide their information. So there's an understanding that when you're using healthcare services in Canada, that there will be information about you collected, and it will be used to be analyzed at the population level. So those are ways to work within existing structures where data are collected for the general population, so to speak, and provided individuals with intellectual disabilities can be identified within that population data. There's more that can be done, or more access. Access may be more readily available. Yeah, so yeah, Eva pointing out, so there's specific concerns around vulnerable, this is a vulnerable group. Any information that has to be linked, yeah. One of the biggest consideration or roadblock that we face is around interpretation of privacy legislation and laws to or other principles to protect data. So that vary widely, and it may require a lot of education on the part of data holders about the mechanisms and the technical ways in which data can be protected. Back to the PowerPoint. So privacy is at the core of a lot of this, and being able to explain to individuals who don't have experience with making data available how data can be protected. One of the key considerations is whether the data need to be fully identifiable, mildly de-identified, or strongly de-identified, because the more de-identified the data is, the less concern there is around privacy. But the more de-identified it is, the more difficult it is to do some of our analyses. So there has to be a balance there. There's also interpretation often in terms of what is de-identified and what is, or what is strongly de-identified and what is mildly de-identified. So it's there's not a very clear path for that, or definitions that are universally accepted. That creates problems as well. The other thing to consider and to work through is how can the following minimize risk to privacy. So technology is something that we really need to think about and to use to best we can through methods like encryption, scrambling of identifiers, and those sorts of things. Laws will also minimize risk. So there are requirements for data sharing agreements. So data is not just easily passed on from one group to another. There are legal documents that get signed off that explain exactly what will happen, what data will be shared, and how it will be transferred and how it will be used. So those are things that can be can assist in moving the process forward. Ethics, so working through Research Ethics Board or Institutional Review Board to work out the concerns that are identified. And statistical methods can also be used to reduce the risk to privacy. So creating computed values, for example, at the level of the data custodian before it's passed on to others. An example of that would be socioeconomic status, for example, or neighborhood income. In order to get that information here in Ontario, the data custodian is able to link the postal code information, which would be considered identifiable, but can link that information to census data, the group level, and then provide that in the data set that is then used in the analysis. So there are ways to access data that is needed, but needs to be sort of manipulated or before it can be passed on to others to protect privacy. And there's also thresholds for re-identification. That has to do with what cell counts get reported or suppressed. So that it would also be techniques that could be used to reduce the risk to privacy. In Ontario, our practice is not to report cell counts less than 6. And so that would not be made available to others. So you have different people who have different levels of access to the data and to report the results from the data so that it doesn't become publicly available. Just spending a bit of time now on the laws that protect personal information or health information. In Canada, the legislation strives to protect both privacy, to both protect privacy and facilitate information sharing for research purposes. So, and that's really, as I mentioned in the introduction, that's the direction that most places are moving towards. And you may be at a different place relative to others, but I think as I said, there's a recognition that there needs to be a sharing of data, and it's possible to do that now, provided there's many examples of how that can be done safely, legally. However, even within Canada, we have overarching national legislation, but then there's provincial legislation, and the provinces have some differences as well as some common features. And importantly, there's interpretation of terms that can differ from place to place. So that further challenges the work that we can do. So we've to date been working at the provincial level in Ontario, and Shaheen, who's on the call, has been doing some work in Manitoba also. I'm going to describe how we access or how data access is enabled in Canada. Generally, there are general terms, but individual level data is typically kept in secure facilities. So in Ontario, we have what's called the Institute for Clinical Evaluative Sciences, and in Manitoba, they have Manitoba Centre for Health Policy. And these are secure facilities that receive data from the administrative operations in our provinces for the administration of health care. So when individuals see a physician or are hospitalized or have other procedures done where there's a billing to the province for that service, there's a need for reimbursement, there's a record of that, and it eventually makes its way to these facilities. And there are unique codes that are attached to individuals so that their information can be linked across all of the data sets that are available through these facilities. There's very limited access to any one individual to all of that data. Only senior analysts would be able to have access to that level of data. They would, for the purposes of linkage, and then they would provide the required databases or data sets as defined by the researchers asking a particular question, and they would be responsible for ensuring that only de-identified data is made available, and that only the data that is required is made available. So at these secure facilities, date of birth, for example, and postal codes would typically be removed. And more, these types of data are being made available through secure online links. And these are individual level data that's been moderately de-identified. But if we want to get even more data to work with directly as a researcher, not within one of these facilities, and not through an online link, secure link, then the data would have to be further de-identified. So we might be excluding things like the particular city and only reporting age categories for individuals as opposed to an actual age. And that could, in some circumstances, then be made available to a researcher. And then when the data is all grouped, it then becomes aggregated data, and that can be made publicly available on a website, so or other means in reports and so forth. So that would be kind of the level of access and data, and how the restricted use gets defined in terms of using administrative health data for research purposes. Now, I'm going to talk more about what we've done here in Ontario. As we've talked about in a previous webinar, we want to be able to present population-level statistics on mortality. So it's important to create a cohort or to create a population that is as comprehensive as we can make it of all individuals with intellectual disabilities. For the purposes in Ontario, we had health administrative data that we could have requested access to through the Institute for Clinical Evaluative Sciences, a secure facility. A number of us are scientists there, including Rob, who's on the phone, Rob Ballo. And so we could, as scientists associated with the Institute, have requested access to de-identified data on individuals who are identified in health administrative data as having an intellectual disability. And that would be done using ICD codes. So the problem we found with that is that not everybody who has an intellectual disability is coded as such in the health administrative data, because those are data sets predominantly used to reimburse for services rendered. And if the intellectual disability was not the reason for providing a service, a medical service or a hospital intervention or procedure, then it would not appear in the databases. So we recognized that there was a need to add to those data sets social assistance data that reflected recipients of a program to which all adults with intellectual disabilities who are eligible to receive a pension through the province. And then the next step, once we have a cohort, will be to link in mortality data. So our research program through which this is done is called HCARD, the Healthcare Access Research and Developmental Disabilities Program. And it's really a unique research partnership in Ontario. This work began actually slightly before 2010 because it required submitting applications for funding to undertake this program of research, and it's a very competitive area, as most of you would know. The partnership involves policymakers in both health and social care or social services, as well as a variety of researchers with various disciplines, from epidemiology to health services research, to clinical researchers. We also have healthcare professionals involved and healthcare planners. We also have mechanisms for involving parents and adults with intellectual disabilities to inform our program. So the group of researchers is quite large now, but it started out with 6 principal investigators, and our nominated principal investigator is Yona Lunsky, and others involved, as I mentioned, are Rob Ballo, Elizabeth Lynn, Barry Isaac, and Virginie Cobigo were the 6 initial researchers involved in this work. So a significant amount of time was spent working with various stakeholders to understand what was needed to be done in order to create a representative, or not a representative, population-based sample or cohort of the population to do our research. The cohort is restricted to individuals 18 to 64 years of age because the disability pension, and that's the eligibility criteria for the disability pension that individuals with intellectual disabilities are eligible to receive. And we looked for the definition of intellectual disabilities was based on ICD codes for TDD, ASD, intellectual disability, select chromosomal and congenital anomalies for which an ID is typically present, as well as FASD. So we've had discussion in previous webinars about whether this is a definition or whether we can have a definition that doesn't include the developmental only disabilities, and so currently everybody is included in our cohort, and our ability to separate out ASD and FASD is very unclear at this point. So our work was completed within a secure facility. So at the Institute for Clinical and Evaluative Sciences, we work with a senior analyst who has special privileges to access individual level data for the purposes of linkages, including any use of personal identifiers for the purposes of assigning value such as age or neighborhood income. Then a researcher, either a PI or trainee or staff, has access to moderately de-identified data to conduct predefined and approved analyses. And then the risk of re-identification is reviewed before sharing beyond the research group. So that's how the privacy concerns are managed within that environment. There are 79 data holdings to date at the Institute, and they cover, they're organized around different types of data sets. Some about health services, so physician billings and hospitalizations. Some about population and demographics, so census, whether an individual is registered to live to register to receive service, Ontario health coverage in the province. There are acquired registries that come into the Institute, and there are derived cohorts. There's files that have to do with financial information. There are national surveys that have been, and provincial surveys that have been provided there too, and so they're able to link to those. There are data sets that simply describe care providers. There are others that are used for coding, mainly related to geography, and others that have to do with the facilities where people are getting care. So we didn't need to use all of those data holdings, but they are all there. I've listed the ones that we've used there, and they're just acronyms, but as you can see, there are a number, there are 5 that were used from the health services category to define our cohort. So this cohort we talk about as the ISIS cohort, so that stands for the Institute for Clinical Evaluative Sciences. But we knew that that would not represent all individuals known to have an intellectual disability. So what we needed to do is to also link in another database that included the codes for intellectual disability for the disability support recipients. As I mentioned, this was restricted to those 18 to 64 years. The challenge that we faced is that that data set belongs to another ministry, not health. So all the health data sets are available through the Institute for Clinical Evaluative Sciences, but this one that we critically needed is managed, is part of a program that's administered by a completely different ministry. So we had to engage with that ministry, convince them of the benefits of the linkage, and ensure them of confidentiality and privacy controls that were being put in place. Because we already had the institute that has the experience with doing this with health data, it was much easier to convince this second ministry that this was a useful thing to do, and that it could be done safely as far as protecting people's information. So the merging of the data then involved the 5 data sets from ISIS and the one from the Ministry of Community and Social Services. We used 1 year of data. We have all years of data available from the health data sets, but the Ministry of Community and Social Services only agreed to provide 1 year of data. We are currently in negotiations, or there are bigger negotiations with them to do this on an ongoing basis. What I want to share with you is next is how long this all takes. So if we don't calculate in the time it took us to secure funding, because that did take some time, but if that's our time zero, the first critical thing that we had to do was to obtain a privacy impact assessment. And that is done by consultants who look at what we propose to do, why, what data elements we are looking at, and how the data will be transferred and kept secure. And it took 10 months for that process to be completed, for everything to be clarified, and for everybody to be satisfied with the process proposed. Then a data sharing agreement had to be signed that was based on this privacy impact assessment. It took an additional 8 months. We're dealing with government bureaucracies, so that can take some time. It took about a month for the data file to be transferred, and then a few months for the linkage to be completed. And then we spent, and we had began that work before, but our cohort definitions had to be tested. So which code should we include? How frequently should a code be found? What other criteria should we incorporate in our cohort definition? So it's a long process, but it's well worthwhile. We've been able to study a number of different healthcare and healthcare access issues with this cohort, and we continue to do that to this day. Before we talk about some of the results, I have another question. So, will you need to undertake comparable linkage of data sets to create a cohort? So how commonly is this in terms of a path forward for people? It looks like for the majority, that's the route that is required. That's the process that's required, and that some have already completed it. So that's wonderful. So we might, hey, I think it would be a good time to hear about, from those who say they've completed this already, on what was similar and what was different from what I've described. I think one who's completed is probably Rob, so. But Shaheen certainly, I know, has experience with this. Do you want to say anything, Shaheen? I don't know if you have a microphone. Possible that she doesn't.
Helen, can you hear me?
Yes.
Oh, it's Rob speaking. There was a question earlier about how we got guidance with respect to linkage at our different organizations, and whether this was done nationally or provincially, and where we got this guidance from.
And did you answer it, or I saw the chat was there earlier?
Yeah, well, so I mentioned that we have, it's usually linkage, the guidance is given to us provincially at the secure locations that you mentioned. So for instance, there's the Manitoba Centre for Health Policy in Manitoba, and there's ISIS at the Institute for Clinical Evaluative Sciences in Ontario. There is really no guidance given to us nationally in terms of linking databases.
Yeah, there is a program currently underway nationally to look at creating a information highway that would allow for linkage across provinces, but that is really it's a big initiative, and it will take some time before we get to that point. Just reading some of the comments. Shaheen, we can't hear you.
I guess it might be useful to comment on Manitoba again. I guess I'm a big proponent of what happens at the Manitoba Centre for Health Policy, which is where Shaheen does a lot of her work. And we can't hear her. Right, so Shaheen has mentioned that they have education data set, and it is much quicker process in Manitoba to link databases from different ministries and departments of the government compared to when you try to do it in Ontario.
Yeah, one of the big differences is that in Manitoba they have already negotiated the shared housing of all these data sets at the Manitoba Centre for Health Policy as a repository for data sets not only from health but also social services and education. And they have many more data sets than we have available in Ontario. And they had, I don't know, is it 30 years now of history doing this? And the other thing is that they that should be emphasized, though, is that when we want to do research in Manitoba, we still need permission from every data custodian. So if we want to use education data, we need permission from education to have their data linked. It's a formality, and they need to know why we're going to use the data, how we're going to use it, and then they know it's going to be done within the center, and they provide approval for it. But we have to ask each data custodian for permission and provide proof of that to the center, and then the center will link the data for us. But they have a lot of experience with it, and it certainly facilitates the work. They guide us through every step of the process. So since 1971, Shaheen tells us. I don't know if it stops people from typing if we move, or if they can still complete the chat.
So this chat box is specific to this question, but we could continue this conversation in the main chat box, which will reappear once we go back to the presentation.
Okay. All right. So I encourage you to do that. I'm mindful of the time, so we're going to go back to the PowerPoint slide. So this slide really emphasizes how important it was to do that linkage, and it was worth waiting for it to happen. Once we linked the disability income data with all the various health data sets, the 5 that we were using, we found that the overlap between the two sectors in terms of who they identified as having intellectual disability was only 30%. So if we only use health data, we'd be able to identify 67% of the population. That could be identified through these data sets combined. And if we only use the disability income, we'd identify 63%. So it's very important to have done this work. And we've looked at and described the differences between who's identified in one type of data set versus another. And there are demographic differences that are likely to be very important to health monitoring. So that's just a bit of results too, and that's the reference there that's been published. So the next step then, to use this cohort to study mortality, will involve identifying deaths. So if we go back to our data holdings, there is an additional data set under the population and demographics category, which is the Office of the Registrar General data set. And it has death records from January 99 to March 2013, and cause of death only until December 2012. So there's a significant delay to this information being made available, but because it will have the same unique identifier as is in all the other data sets held, it can be linked to the cohort identification that we have. But because we created our cohort in 2009-10, we don't have a long follow-up in terms of cause of identifying death in that particular group at this time. The Office of the Registrar General's Death Database has 58 variables. I've identified 21 that align with some of the data that we talked about in the previous webinar as being desirable to have. So as you can see there was a change in terms of how cause of death was coded or which cause of death, whether it was an immediate or primary. The terminology changed between 2002 and 2003. But there are up to 12 causes of death code that can be included on any one record. We know the date of the death, the age of the death, place of death, the antecedent cause, and whether it was accidental, suicide, or homicide, if an autopsy was performed, and whether those findings were used to determine the cause of death. So a fairly rich data set that we could link with our cohort identification and look at the mortality experience going forward. The question I have is, how long should a cohort be followed to report meaningful mortality rates? I don't know if any of you have done this before, but we have people living in Ontario who were 18 to 64 years of age in 2009, 2010. We report annual mortality rates for them going forward. Do we need to wait till we have mortality data that is more than 5 years to have meaningful information? So a few people, everybody so far is saying we should wait till we have 5 years of data, which would mean waiting till we have the 2014 data on mortality. To have followed this cohort long enough. The size of the cohort is over 66,000 adults. Very large. So I'm not going to put up the other slide, but because I'd like people to continue typing here, but I just wanted to let you know that we don't have mortality results at this point, but that the analysis of the cohort will be undertaken by Rob, who's on the phone, and a colleague, Elizabeth Lynn, and that we're also looking at mortality, but as a competing risk, in an analysis of frailty as a predictor of admission to long-term care in a slightly different cohort than this one, but using the same data sets, but a cohort from 18 to 99 years of age. And Shaheen is also involved with work that she is doing in Manitoba, and we're hoping that we'll be able to compare our mortality rates across provinces. But that requires looking at the comparability of the data and so on. But our cohorts are identified very similarly in the two provinces, so we're hopeful that that will be doable. So maybe ask if Rob or Shaheen have anything they'd like to add at this point.
Can you hear me, Elaine?
Yes.
Okay. Sorry. For the mortality, we do have the vital statistics file, which has the mortality information, the date of death, and the cause of death. So very similar to what you described. for Manitoba. So that file could be accessed through the MCHP. And in response to the question, how many years of data for the general population, the mortality rates have been calculated and reported for based on 3 years of data, but also 5 years of data. So I will say at least 3 years of data. But as you mentioned, it's a very similar kind of process, and we are working with very similar definitions. So hopefully we will be able to produce comparable data across the two provinces.
Thank you. Rob, is there anything you wanted to add about Ontario?
Well, I just think information that Emily providing is actually very useful in that text. Emily, have you published that information?
Yes, it's available on the web. I can send a link.
Excellent.
Oh, and Hélène, I don't know if you can answer that. There's a question from Matthew that I couldn't answer. In Canada, is there protection against forced data disclosure?
I'm not sure I understand what is meant by forced data disclosure. I think if you're using the health system in Canada, your data will be supplied to the government for purposes of reimbursement, and your identity will be known on those. You have to be eligible to receive those services because they're paid for by the province. So it doesn't really apply because of the data are being collected for the purposes of administering a benefit program, there is a precedent of making that data available to improve the system. And that's the onus is on us requesting these data to be able to show that the reason we're requesting it is not to serve some individual career ambition, but it's to improve the system so that because taxpayers are paying for the services, and therefore the research is meant to provide a benefit.
Yeah, I guess individuals would not be forced to provide their identity.
Our frailty measures. So we're using data collected through using the resident assessment instrument, which is used internationally in many, not everywhere, but in many places. And we've created a frailty indicator based on the activities of daily living and other medical conditions that are identified in there. So we're almost ready to publish that.
Brilliant. Okay, thank you.
Coming out soon. But the importance of understanding mortality in a study like that as well, where looking at time to event analyses, it's important to be able to deal with mortality as a competing risk. So just to summarize, data linkage may be necessary to more completely identify cohorts for mortality studies. So it's something that I think we all need to be thinking through and being able to demonstrate that the data that you have is sufficient in terms of identifying the population at risk. Certainly was an issue for us, and we would have had very skewed results potentially if we'd only used the health administration data. It introduces additional health information privacy concerns, and particularly in our case because the other ministry, the Ministry of Community and Social Services, does not have a history of using data in this way for policy decision at the population level. So there was a lot of education and working through those issues with them. It's important to be aware of privacy legislation, and use that as to support what you're doing. As I mentioned, a lot of legislation is moving towards the balancing the need to protect privacy but also make data available. Steps from the data request to data access can take several months, even years. So if you're going to do this, you've got to be prepared for that. And considerations need to be given to the length of follow-up, because you can identify your cohort, your study population, but how long should you follow them in order to provide reliable mortality statistics? And I think that's something that we can now start to have a discussion about as we talk about how we can make comparators across countries. So I'm sorry, I haven't been able to really follow the chat. There's a lot to manage when you do this. So thanks, Rob, for answering a lot of the questions that came up through there. And I'm hopeful that we can save the chat and have it available, so that I'd like to be able to look at it more closely and get back to people.
Yes. We can certainly compile that for you, and that will be part of the meeting notes.
Absolutely. Okay, thank you. That's wonderful. So the next slide, I would turn it over back to Pauline to tell us about our next seminar.
Okay, so the next seminar will be in October, November this year, and on the agenda is the English experience of data linkage, and that's linking data between registers of people who have intellectual disabilities that are held by GPs and national mortality data. And we were going to talk about the impact that that has had. However, as with the best things, I've been in contact with Giles this week to see if he's going to be able to talk about that. He's happy to talk about where we've got to, but we won't be able to talk about much impact because the data linkage hasn't actually happened yet, which goes back to my comment about, it's taken 2 years to get this far and we're still not quite there yet. But Giles is confident that he can sort of engage in a discussion about some of the challenges that have been had and where we're at that time. Now, I wonder if in the light of that we might want to, a bit like the very first webinar we had, we might want to have a little bit of input from everybody else who's already linked data, because it sounds as though there's quite a lot of experience out there about linking data. And think about if people are happy to send a couple of slides and then talk about what they've done and some of the challenges they've faced and how they've overcome them. I think that might be quite a good use of the time. I hope that sounds okay. I'll email around the suggestion, and if people do want to contribute slides and then chip into the discussion, then I think that would be really helpful. The other thing that I think has come out of this webinar, and Helene, thank you so much, it was a really helpful webinar, is that I wonder if we can compile almost like a working document, and it's coming back to your comments about the benefits must outweigh the potential harm, and if we all put our heads together and think about the benefits from data linkage and the impact of data linkage, and if we can put all of those examples together in one document and then use them as a kind of tool to encourage, cajole, motivate in our own countries, that might be helpful. So I don't know how people feel about that, but certainly I think from our perspective, just to have a combined document that's sharing our experience would be helpful. So again, I'll email around about that, and if people can send me their ideas, then I can compile that and send that round for everyone to use as they feel appropriate.
Pauline, I have a document here that was discussed or developed for Canada where they talk about data linkage generally, and they do have a section on successes and impacts, and I wonder if sometimes we need to think about what's been done, not necessarily in intellectual disabilities, but for other purposes, in cancer or in other places, because we may not have impacts yet related to intellectual disability data linkage, but and talk to policymakers and say that, this is akin to what happened in, with this particular finding in cardiovascular health or something like that.
I think that, yes, I agree. I think that would be helpful. I think that given your points, though, about the additional vulnerability and concern that there is about people with intellectual disabilities, we might also just want to bear that in mind too.
Absolutely, yeah.
But yes, that would be really helpful. Thank you. So there are a couple of comments in the chat box. I don't know, do we need to go through those? So Chris saying, is it worth discussing bottom-up intellectual disability mortality reviews, so individual reviews of death, in addition to population level data linkage at some point in the series? And yes, absolutely, I agree. I think that would be really helpful. And then Eva, you've got experience that you could share. That's fantastic. Thank you. And there's lots of other people typing at the moment. Oh, Julian, fantastic. That sounds great. If you're writing a position paper on utility data linkage, that would be fantastic. Thank you. Chris, are you still there? Can you just talk a little bit about the... oh, I've lost you.
Chris, is he still here in the chat box?
Okay. Okay. Oh, and thank you, Tony, about Darcy's paper. Would you be able to send a copy of that over and then I can share it? Is it freely available? Is it open access? Or if you could send a final draft, I don't know, or a link for people to be able to access it if they're able to, that would be really helpful. And Matt has got a question for you, Helene, I think. Are you still there? Views about pseudo-anonymisation.
I'm not exactly sure what is meant by that. There's an interesting process done in Manitoba when we bring data into their center on data on intellectual disabilities into their center, whereby only core elements are shared across data sets, and then it's really, I forget, I'm having a hard time explaining this, but there's ways of removing identifiers from one part of the file and then reattaching them after the linkage has occurred. So I think there are experts who do this within these institutes, like the Manitoba Centre for Health Policy and the Institute for Clinical Evaluative Sciences here, and they really it needs to be left in their hands to ensure that that is done properly.
Okay.
So I think I would direct, like if somebody's ready to do that kind of thing and doesn't have access to expertise there or needs somebody to explain it further, it would be best to deal with the data custodians who manage this data and protect it like that all the time.
Yeah. Okay, thank you. Now, is anyone else still typing? So, Daniel, can I have a chat with you separately about the case note review? Brilliant, thank you. Given that we've now got funding for the National Learning Disability Mortality Review programme in the UK, it would be really helpful to join forces to review that. So thanks very much. Okay, so thank you everybody. I think it's been a really, really helpful webinar, and thank you very much, Helene, again. And thank you, Emily, for being so calm and collected again while we're all panicking away trying to work our way through this. So everyone saying good night now. So thank you. Thanks very much, everyone. Bye.
Thank you. Bye-bye.
Bye-bye.